Hi class, it's Professor Kemper, and today we're going to be talking about coronary artery disease, and then we'll kind of go into hypertension. So let's get into it. So here are those student learning objectives, what I would like to get across when it comes to coronary artery disease, and also these will be similar to hypertension when we talk about hypertension. So here's the agenda. It's really quick. As you can see, this is only 15 slides, so it shouldn't take us too long to get through. So we're going to be starting with the pathophysiology. We'll talk about risk factors and clinical manifestations of coronary artery disease, and then prevention, and then some medications. So cardiovascular disease is still the leading cause of death in the US for both men and women, and this is not specific at all to a certain race or ethnic group. It can affect anyone. Coronary artery disease is most commonly the type of cardiovascular disease we see in adults, and so because of this, we really need to recognize, assess, and be able to educate our patients on prevention and treatment so that we can potentially slow or stop the progression of the disease. And the most common cause of coronary artery disease is atherosclerosis and arterial sclerosis. So what is the difference? So atherosclerosis is accumulation of lipids, calcium, carbs, fibrous tissue, and plaques on the lining of blood vessels, and this results in stenosis, obstruction, aneurysm, ulceration, and/or rupture. So the picture on the left. And then arterial sclerosis is the process of thickening and stiffening of the muscular layer and the endothelial lining of the arteries. So as you can see on the right side of the slide. So both contribute to alteration and structural damage of those vessels, and that results in blockages, ruptures, and potentially life-threatening processes like a myocardial infarction. So the patho. So usually coronary artery disease is a slow, insidious process where there's an inflammatory process in response to risk factors such as sedentary lifestyle like high fat, high sodium diet, diabetes, smoking, hyperlipidemia. Maybe people have some genetic predisposition. So this really creates those atherosclerotic plaques that start to build up on those blood vessel walls. And really the first sign we see of coronary artery disease are these fatty streaks inside of the arteries, which appear when we have excessive LDL cholesterol in the blood that invades the endothelium, and it accumulates and causes inflammation. So this attracts immune cells like macrophages, and they start to eat those up. But when they do that, they turn into foam cells, and these foam cells release an endotoxic substance that continue to then damage the cell wall, and it creates a cascade of further accumulation of lipids, and eventually that surface of the vessel wall becomes necrotic, and it produces a fibrous cap. And then the lumen of arterial wall, it starts to get narrowed. So when we get larger and larger plaques that create further narrowing of those arterial walls, we end up having less and less blood flow and thus less oxygen when we need it. So this results in what we call angina. And then what can happen is that angina can become unstable, and it can result in an MI, myocardial infarction, or acute coronary syndrome, and that can lead to then heart failure and lastly death. So it's really a slippery slope once this cascade of events starts to occur, but again, it's progressive, it happens over time, and what we as nurses can do is educate our patients on how to prevent that from occurring or slowing the process. Risk factors for coronary artery disease. So some of the risk factors for coronary artery disease, this is where a lot of our nursing education is going to stem from. A lot of money and a lot of research has gone into learning more about cardiovascular disease, and so some epidemiologic studies have shown that several factors, which are listed on the slide, can lead to a person's increased probability of developing heart disease. So let's start on the right side with the non-modifiable, or those risk factors in which a person has no control over. So age, men who are over 45 years old and women who are over 55 years old tend to have a more significant increased risk of developing coronary artery disease. Men tend to develop it at an earlier age, and thus this is why they are at higher risk of developing coronary artery disease over women. And then familial predisposition and or genetics. So family history with a first-degree relative with coronary artery disease places someone at a higher risk of developing that. And then we have a list of modifiable risk factors, so those that a person may have control over by changing their lifestyle or a personal habit or by using medication. So things like tobacco, diet, hypertension, diabetes, obesity, stress, physical inactivity, metabolic syndrome, or chronic inflammatory conditions. When these are well controlled, that risk of developing coronary artery disease goes down. So let's stop here and just talk about metabolic syndrome for a minute, because as you saw on the last slide, this is a modifiable risk factor for coronary artery disease. But what is it? Well, metabolic syndrome is a cluster of metabolic abnormalities where a person has at least 3 out of 5 of these risk factors. So low levels of HDL cholesterol, so less than 50 milligrams per deciliter in women, and then less than 40 milligrams per deciliter in men. Another one is an elevated waist circumference, so greater than 35.4 inches for males and greater than 31.4 for females. An elevated fasting blood glucose of greater or equal to 100 milligrams per deciliter on 2 separate occasions. Elevated triglycerides that are greater than or equal to 175 milligrams per deciliter, or those who are currently on medication treatment for hypertriglyceridemia. And then finally, high blood pressure, so systolic blood pressure of greater than or equal to 130 over greater than or equal to 80. And when you think about it, many individuals with type 2 diabetes fit this clinical picture. But this metabolic syndrome is one of those things that definitely increases risk for coronary artery disease. So clinical manifestations of coronary artery disease really depends on the degree of narrowing of those vessels and activity of the client, but also the location of the narrowing or obstruction of blood flow. But coronary artery disease is also known as the silent killer, so your patient could end up not having any symptoms or really subtle symptoms until really it's too late. Sometimes they will appear pale because of lack of blood flow. They could have dizziness, sweating, nausea. And if the disease becomes severe enough, they may experience what we call angina or chest pain that is from myocardial ischemia or lack of blood flow. And over time, this can become irreversibly damaged and result in, again, myocardial infarction and sudden cardiac death. So as the nurse taking care of a patient with coronary artery disease, where are your focused assessments going to reside? Probably the first thing you'll be thinking about is a cardiac assessment, right? So this will include inspection, palpation, and auscultation of the chest wall. You got to ask yourself, do they have S1 and S2 heart sounds, or are they having irregularity when you auscultate? Do they have any jugular vein distension? Do they have palpable pulses in all extremities? Are they equal bilaterally? Do they appear pale? Are they diaphoretic? How is their pulse and their blood pressure readings? And remember that we can't just obtain one set of vital signs, we have to trend them. Do they have orthostatic hypotension? But also looking at them, how is their general appearance? Do they look ill? Do they appear the color gray? I guarantee you in your lifetime as a nurse, you will see patients that you'll notice will turn gray, and that is not a good sign. You need to act fast. Anyway, next up is respiratory. So do they have a cough? Any crackles or wheezes in their lungs? Are they coughing up blood? Neurologically, how's their level of consciousness? Are they having any issues with memory, short or long term? Are they having dizziness? Do they have a headache? Any visual changes? GI and GU. Are they having any abdominal distension? Any bladder distension or reduction in their urine output? All things we want to be thinking about when we have a patient with coronary artery disease, because it's not just attacking one system, our cardiac system. The vasculature goes to all of our organs, right? So we want to be doing broadening our focused assessment based off of this diagnosis. So here's some labs and diagnostics we typically will draw from blood when we're working up someone for coronary artery disease. So normally we would grab a fasting lipid profile, and this is to look at a person's total cholesterol, their LDL, their HDL, and then also their triglycerides. And this is to evaluate a person's risk for developing coronary artery disease. So high cholesterol levels obviously increase a person's risk of cardiovascular disease, and that's regardless of their age. And based off of a person's 10-year risk for atherosclerotic vascular disease, physicians may place patients on a statin, which we will talk about in the next coming slides. And another lab test physicians may draw is fasting glucose and HbA1c levels. And this is to look for hyperglycemia and specifically diabetes, because remember that metabolic syndrome, it places patients at a really high risk of developing coronary artery disease. So we want to rule that out. Or if we do have findings of that, we want to educate the patient to help them control their blood glucose levels. Or we might put them on medications. We might find that they are diabetic. And that's another set of education that needs to go into that person's plan of care. They may also draw a BUN and creatinine. This is to look at kidney function, because coronary artery disease can destroy the kidneys. And we obviously don't want that to occur, because then we have other problems, right? And then finally, a CRP. This might be drawn, and this is a protein produced in the liver, and that's in response to systemic inflammation. And it's thought to play a role in the development of atherosclerosis. So although it's a non-specific lab, it may be used to help see the entire clinical picture. They use this also to predict cardiovascular disease risk. So the higher the level, the more at risk the person is for developing cardiovascular disease. So these are just some of the major complications that can occur because of coronary artery disease, but it's not enough to know what these are. You as the nurse, you need to recognize the clinical manifestations of these complications so that you can intervene and also educate. So something like a TIA or a CVA or stroke, how do you know when your patient's experiencing this? How do I know that they have renal damage or heart failure? What are the signs and symptoms? What are the clinical manifestations? What are the labs I should be monitoring? And what can I do to prevent these complications from occurring? This is where that critical thinking comes in. So it's not enough to just look at this slide and go, oh, I know what those are. How are you going to, what subtle changes are you going to see in your patient to make you recognize, oh, they are having a complication, and what are you going to do about it? Okay. So medication management of coronary artery disease. So if diet and exercise is ineffective at controlling the progression of coronary artery disease, aka reducing their cholesterol levels, then physicians will place that patient on lipid-lowering drugs. So first choice is usually a statin, and I believe this is the most commonly prescribed drug in the United States, but I could be wrong. So statins inhibit the enzyme involved in lipid synthesis, which will ultimately lower total cholesterol. It'll also lower LDL, and it'll increase HDL and lower triglycerides. We want to watch out for adverse reactions like myalgia and arthralgia, and this can result in rapid muscle breakdown or rhabdomyolysis if the patient continues to take this drug. So we want So rhabdomyolysis, it can lead to an acute kidney injury, and this is a serious side effect of a statin, so we want to make sure that our patients call us back about it. Any type of, muscle cramps in their legs is what I usually hear, but cramping in general, anywhere, we want them to call us, especially if we see these side effects occur when they have just started a medication, so like the first 2-3 weeks in, they start to have cramping, and so we want them to let us know. Usually statins are administered in the evening, and this is because this is when our cholesterol is being produced by our liver, so if we give this drug while the cholesterol is at its height, or peak in production, we are going to affect that total cholesterol better, obviously. So that's why we try to have our patients take it in the evening. But I've also seen it scheduled in the morning. We also want to monitor liver function, and we want to advise our patient to watch for signs and symptoms of liver failure because this is metabolized in the liver. And then we have fibric acid derivatives, which decrease the synthesis of triglycerides and they increase HDL. And these are contraindicated in those with severe liver disease and kidney disease. And sometimes these will be used in conjunction with a statin, but we really want to watch that patient kind of closely, again, because that medication is being metabolized in the liver and the kidneys. So adverse side effects can include GI upset, myalgias, and pancreatitis. So then we have bile acid sequestrants, and these come in a powdered form, and these are really mixed with a glass of water, and the patient really chugs it quick because basically what it's doing is it's blocking bile acid in your stomach from being absorbed in your blood, and it grabs onto the bile acids in the stomach and it doesn't allow them to be absorbed. So this means that bile acid sequestrants should not be taken with other medications because it'll grab whatever is in the stomach and it'll prevent it from being absorbed during the time of administration. So side effects with this are going to be GI, so like constipation, abdominal pain, sometimes GI bleeds. Finally, we have ezetimibe. Ezetimibe. Okay, I can't say this one. Anyway, don't make fun of me. So anyway, we have this medication, and it's a cholesterol absorption inhibitor. And it's doing just that. It's decreasing absorption of dietary and biliary cholesterol in the small intestine. And this usually is better tolerated than the bile acid sequestrants, and it can be used in combination with statins. So this is contraindicated again in liver disease, which I think we can assume is with probably all of these, right? And then mostly GI side effects, and again, the myalgia and arthralgia for the rhabdomyolysis. So to kind of end this lecture, I want to just touch upon the patient education priorities when it comes to coronary artery disease. Obviously, we want to have a chat with our patient about how they can control their cholesterol, whether this be their medications or through dietary measures. We want to limit their intake of high saturated and high fatty foods and foods high in cholesterol and salt. We will also want them to increase their physical activity regularly. Cessation of tobacco use. This is a tough one sometimes to have a conversation about because I've experienced patients who just kind of, you bring up the subject and they shut you down. Sometimes we have to be a little stealthy, and sometimes we just have to assess whether our patients are ready to talk about those subjects. The other thing we need to educate our patients about with coronary artery disease is how they can manage their hypertension, and we'll be talking about that in the next lecture. And we also want to help them control their diabetes because, again, this highly contributes to coronary artery disease if it's not controlled. And that is it. That was a quick down and dirty of coronary artery disease. We have some fun activities that we're going to do in class, and if you have any questions, feel free to ask me in class or shoot me an email. All right, thanks for joining me today, and I'll see you in class.